Okay. Um, Today's presentation is going to be on infection prevention and control. Um, we have some members of integrity staff present for this presentation, and this is not a very big screen, so I don't know how well you guys can see, but a lot of it will be just talking. So, couple disclaimers is, first one, the guidelines in this presentation are comprised of the most recent recommendations from the CDC, IDPH, and CMS. The guidelines may differ from integrity policies, and integrity policies may differ from one facility to another. So keep that in mind and reference your administrator, DON, and local health department for the policies specific to your facility. And then this presentation is being recorded for submission to McKendree University staff for a grade, so please keep any patient health information private, no patient identifiers. Okay, so my name is Danielle Crum. I'm a BSN student at McKendree, and I have worked mostly ER since February 2014. Did some travel, ER, St. Louis area, worked critical access for a couple years, and I've been in the float pool with integrity technically since August 2019. I only worked 8 hours a month for the majority of the beginning of that for 2019-20. When COVID hit, I really was just primarily in the ER and have been full-time, part-time-ish, just working with integrity since February this year. I really do have a passion for infectious diseases, like the medical cases, the really severely ill. Trauma is really cool and everything, but whenever you get the patients that come in the ER that are really sick and they've got metabolic imbalances, they've got SIRS leading to sepsis, multi-system organ failure. We get to do like life support interventions, mechanical ventilation, lots of fun stuff. It's really fun figuring out like what's going on, and a lot of that starts with infection. Basic review of infectious diseases and high-risk population for the geriatric population. Going to go over some relevant processes and policies, isolation practices and tracking, our diagnostic testing and rationale. I really wasn't wanting to focus mostly on COVID, but kind of just turned into that. It is what it is. So lots of COVID stuff today, and how we're tracking symptoms and vital signs, visitation, vaccination, and then a little bit on antimicrobial stewardship. 2 goals that I was wanting to see and try to help with was more specific to Carbonell's facility, the tracking of vital signs, monitoring residents for signs and symptoms related to COVID, hopefully getting better adherence to the CDC, CMS, and IDPH guidelines for the tracking and transmission precautions. So, high risk. Geriatric population and long-term care facility residents are at increased risk for infectious diseases. CDC cites that there are age-related declines in immunity that may affect responses to immunizations for flu and other infectious agents, and increased susceptibility to TB. There are phenotypic and functional changes in T cells, mobility and function, incontinence, dysphagia, comorbidities, poor functional status, and age-related skin changes, malnutrition. These are all highly found in long-term care facility residents and can increase their risk. Medications, drugs that affect the level of consciousness, immune function, gastric acid secretions, and normal flora, including microbial antimicrobial therapy, as well as invasive devices, urinary catheters, feeding tubes. Those also heighten susceptibility to infection and colonization. Dependence on activities of daily living. Their limited functional status makes a lot of them dependent on us for their ADLs, and that exposes them to closer contact. Having healthcare workers in close vicinity with these high-risk population residents increases the risk. And many healthcare workers, especially in long-term care, are poorly informed and less compliant with infection prevention control. Limited time and limited resources can also cause a delay in detection. So, impact of infection prevention and control on the unit: increased morbidity and mortality. Pneumonia and lower respiratory tract infections remain the leading cause of mortality in nursing home residents and a primary reason for the resident to transfer to a hospital. Rehospitalization and extended hospital stays. Healthcare acquired infections can cost up to $2 billion per year for hospitalizations alone. Other increased healthcare costs. Antimicrobial stewardship programs have in studies shown they can save up to $1.5 trillion nationwide annually in long-term care alone. And antimicrobial resistance, it's estimated up to a third of the 1.5 million nursing home residents in the USA are colonized with at least one antibiotic-resistant organism. This presentation aims to address some of the key components of infection prevention and control that can protect our residents, staff, visitors, and family. Keys to outbreak control include early identification of infectious outbreaks, minimizing the spread, non-pharmaceutical interventions such as hand hygiene and transmission and standard precautions. So, the education part on infections: there are 4 types of organisms that can cause infections: bacterial, viruses, fungi, and parasites. A review of 2,789 outbreaks in long-term care facilities showed the most common outbreaks were respiratory infections, followed by GI infections, then skin and soft tissues and eyes. And the most common single pathogens were flu and group A strep. And urinary tract infections are the most common infection and perhaps the most overdiagnosed infection in nursing homes. Approximately 3 to 7% of nursing home residents with an indwelling urinary catheter will acquire a UTI with each day the catheter remains in place. By day 30 following catheter insertion, the prevalence of bacteria in the urine is almost 100%, and it is estimated that 50% of those will develop symptomatic catheter-related UTIs. Transmission of infections can occur through person-to-person contact, contaminated food and water, and problems in practice. Preventing transmission. Even before COVID-19, the CDC main recommendations are to avoid close contact with the sick, avoid touching your eyes, nose, mouth with unwashed hands, clean and disinfect frequently touched objects and surfaces, stay home when you are sick, cover your cough and sneeze, source control and masking, the 6-foot rule, and universal and transmission-based precautions. Hand hygiene remains the #1 way to prevent transmission by soap and water hand washing or with alcohol-based hand rubs. Keeping in mind that C. diff spores require soap and water. They are not killed by alcohol, and surfaces must be cleaned with a bleach solution for those. So standard and transmission-based precautions. Standard precautions are used with all patients, regardless of their known or suspected infectious status, and it assumes that any patient's blood or body fluids may be infectious. PPE is based on the nature of the patient interaction and potential for exposure to infectious material. Then transmission-based precautions are, in addition to standard precautions, using transmission-based precautions for patients with documented or suspected infection or colonization with highly transmissible or epidemiologically important pathogens, for which additional precautions are needed to prevent transmission. So currently, we were doing 2-week isolation, contact, and droplet precautions and isolation for all new admits and residents who have been exposed. Now, if they are fully vaccinated or within 90 days of confirmed COVID-19 infection and have not had prolonged close contact with someone, we don't have to do that 2-week isolation across the board anymore. And that was regarding COVID. That was a policy that was specific to that. The CDC has a list. You can go to the website that has Appendix A, and it has a list of the guidelines for isolation precautions for every single organism that may be suspected or may be found in residents.
You got a line with
She's doing a webinar.
I've got some.
Then for our purposes, what we've been doing is putting signs on the resident's door. The CDC provides these stop signs that you place right on the resident's door that shows all staff, visitors, any other residents that they are on precautions and what precautions to adhere to. And we have also been placing the infographics on how to put on and take off PPE on the doors as well. And then I'm gonna end up running out of time, so let me skip the video. That's a video of donning and doffing PPE properly. These transmission and standard precautions are especially important in preventing bacterial and viral infections such as the flu and COVID-19. Coronaviruses are a large family of viruses that cause illness ranging from the common cold to more severe diseases such as MERS and SARS. So COVID-19 is the SARS coronavirus 2. On January 30th, 2020, the World Health Organization announced COVID-19 outbreak as a public health emergency of international concern. COVID does not cause very severe illness in a lot of people. There's a lot of asymptomatic carriers, but for long-term care, there's a higher mortality in people over 60 and in people with underlying medical conditions such as cardiovascular disease, chronic respiratory disease, diabetes, and cancer. Going into COVID pathophysiology, there's a lot going on. It's not completely understood. The big picture is that virus enters your body, enters your cells, it takes over your cell's machinery to begin replicating itself, and this destroys the cell and triggers the immune system and causes inflammation. The main cause of death is acute respiratory distress syndrome, triggered by uncontrolled systemic inflammatory response. Large amounts of pro-inflammatory cytokines are released. You've probably heard of the cytokine storm. Once the macrophages enter the cell, once they're alerted, they start to eat the cells the germs, the cells that have been infected. They leave a lot of cellular debris. They trigger your immune response. The B cells and T cells respond. You've got cytokines, IL-6, IL-1, and tumor necrosis factor alpha are the three main ones that cause widespread like systemic inflammation. They cause the endothelium to dilate, increase capillary permeability. Fluid seeps into your alveolar and interstitial spaces, increasing pressure. You get alveolar collapse, pulmonary hypertension, and clotting cascades are also triggered, creating microthrombi in the capillaries, which decreases gas exchange, decreases your partial pressure of oxygen, and also these cytokines and inflammation markers, they travel through your system. They stimulate chemoreceptors that tell your sympathetic nervous system to increase your heart rate and respiratory rate. They also release prostaglandins that tell your hypothalamus to increase your temperature. Excuse me. So you've got fever, you're coughing up the cellular debris, you've got cough, productive cough, increased heart rate, increased respiratory rate, and this all starts in upper respiratory, but once it spreads systemically, you've got systemic vasodilation with decreased total peripheral resistance, which causes hypotension. And then the hypotension, poor perfusion to your organs, you get multi-system organ failure. And also, a lot of people have heard that it enters through your ACE2 receptors. This is kind of a crude drawing from my notes, but the renin-angiotensin system is found in multiple areas through your body, not just specific to the lungs. So when the virus enters, wherever it enters, it's going to downregulate your ACE2. The two axes of the renin-angiotensin system, they kind of balance each other. So like vasoconstriction, inflammation, insulin resistance, those are all good things at certain times. If you cut yourself, you obviously want a clot to stop the bleeding. But these two axes, they balance each other out, and with downregulation of the ACE2, that arm, that angiotensin 1.9 and 1.7 are just unchecked. Or they're not there to check the other arm, rather. So the common signs and symptoms are fever and chills, cough, shortness of breath, fatigue, muscle and body aches, headache, new loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, and diarrhea. And then this infographic shows all of the systems that can also be affected from the systemic inflammation. I also saw that studies are showing that this virus, the SARS-CoV-2, can cross the blood-brain barrier. So a lot of symptoms that people aren't as familiar with are like the neurological symptoms, the long-term damage, so the like long haulers, the post-COVID syndromes, the systemic vasculitis. Every organ can be affected. Some neurovascular changes can even lead to neurological and neuropsychiatric symptoms. You'll see problems with sleeping, cognitive impairments, anxiety, post-traumatic stress, prolonged agnosia and aglesia, headache, dizziness, vertigo, confusion, delirium, restlessness, and then even healthy people can have long-term pulmonary fibrosis. There's your long haulers. So the virus that causes COVID-19, the incubation is 2 to 14 days. A lot of times you'll see the patient get better, and then they may have a rapid deterioration on the 7th through the 10th day. Most cases are asymptomatic or pre-symptomatic. There's mild illness, moderate illness, and severe illness. So individuals with severe illness will have SpO2 less than 94% on room air. their PF ratio will be less than 300. That obviously doesn't apply for people with chronic respiratory because they already have less than 300 PF ratios. They can have respiratory rates greater than 30 reps per minute and greater than 50% lung infiltrates. On CT and X-rays, you'll see like ground glass opacities was the big term that was all over their CTs, saying suggestive of COVID-19. It's really not a specific finding, but that was what the radiologists I saw were calling a lot of it. Critical illness, people can go into respiratory failure, septic shock, and multiple organ dysfunction. So the transmission of COVID-19, primarily it is droplets, so through your cough or sneeze. It can be found in droplets that are less than 5 microns, which that is what is considered airborne. But airborne precautions aren't typically recommended unless there's going to be an aerosol generating procedure. So usually just a face covering or surgical mask is sufficient unless you're doing those aerosol generating procedures. And of course, direct contact by vector or fomite transmission. And then we have our recommended PPE is based on the county transmission and facility positivity rates. Right now we are all wearing N95s because of facility associated case. COVID-19 testing. If a facility has had no new cases within the past 14 days, then serial testing of unvaccinated staff occurs, and the minimum frequency is based on county positivity rates, based on the CMS data and CMS requirements. And that's really long. I'm not going to read all that, but the CDC, IDPH, CMS, they are still requiring that every resident be screened for their vital signs, and then by a nursing staff member at least once a day for signs and symptoms associated with COVID. And then if they have COVID or they are positive for the screening, we need to be increasing that to at least 3 times per day. And that's to monitor the progression. So vital signs and screening should be monitored for every residence with a tracking tool. You guys have one in place already here. Carbondale did not, so I made this tracking tool for them. There's one for 3 times a day that they just use for everyone, and then if they need to be increased to every 4 hours, there's one for that. And then I believe this is the one that you guys are using here. So the isolation policy, it's a 2-week policy because of the incubation period being between 2 to 14 days. We put the signs on the door, and ideally we will track who has been placed on precautions, what the rationale is, and for how long, if there's an end date. So new admits, readmits, the 2 weeks. Supplies should be in a bin outside of the door. I believe you guys have that here as well. And then designated linen and trash bins in the room. And then just isolation tracking, resident name and room number. You can put the type of isolation. So contact, droplet, airborne, and then rationale and start date and end date. Visitation. So we obviously are not doing visitation indoors right now. The facility shall not restrict visitation without a reasonable clinical or safety cause consistent with that CMS guideline. So there was like 7 to 8 page long. I can copy and paste from all 3 of the websites, but it's very specific. Some of the big takeaways were if the resident is fully vaccinated, the facility rate is under a certain amount and the county rate is under a certain amount, they can choose to have close contact with their visitors. Screening of their visitors 24 hours in advance is no longer required. We must continue to screen everyone upon entry to the facility, and compassionate care visits are always allowed. It is required that there's a written policy for every facility. This is just a copy of your guys' policy here. And a copy of the monitoring tool for everyone entering the facility. Vaccination is how we are going to end this pandemic. So, my favorite facts on vaccinations, variolation dates back to the 3rd century BC in Egypt. They were taking smallpox scabs, they were grinding them up and either cutting your skin and putting this ground up scab in your skin, or putting it up your nostrils to cause a mild case of the smallpox. But those mild cases were not leading to death. And then your immune system was prepared for if it did encounter the smallpox in the future. And then smallpox was declared eradicated in 1980 by the World Health Organization in natural cases. The last natural case was in 1977, but the last case of smallpox in general was in 1978 in Britain. Janet Parker, she was, it's thought that she was in her photography studio above one of the labs that was studying smallpox, and that it may have traveled through the air ducts, and she got it. 260 people had to be quarantined and isolated. She died a very horrible death. It was really bad. The CDC in Atlanta, Georgia, and one lab in Russia now are the only 2 places in the world to keep the smallpox virus for any purpose. And the CDC also stockpiles enough vaccines to vaccinate the entire U.S. if there was ever to be an outbreak again. I always thought those were cool. Types of vaccinations, we can call them 1st, 2nd, and 3rd generation. So the 1st generation would be killed or attenuated viruses. So like taking the virus itself, either attenuating it where it's not as deadly or harmful, or killing it and just injecting it into the host will activate the immune system. 2nd generation, instead of injecting the whole virus, you only inject the antigen part, so the purified protein like the spike protein for coronavirus. This process does still have to be grown in yeast cells or attached to another virus like adenovirus. And those are usually grown in an egg. That's how they grow them, so it still takes a little while. And then our 3rd generation, the mRNA vaccines. So these have been under development for decades. The issue with them was once the mRNA was injected into your skin, your body pretty much eats it up. It does not last in your system, and it wasn't until 2005 that they found a delivery method by encasing the mRNA in a lipid nanoparticle. The body doesn't break it down. It can cross the phospholipid barrier and enter your cell, and then it just gives the cell the instructions, so the RNA, on how to transcribe that specific protein, so the spike protein, and it shows 90 to 95% efficacy. We have Pfizer and Moderna currently are the mRNA vaccinations available, and then Johnson & Johnson is a adenovirus 2nd generation vaccination that are available currently. And then AstraZeneca and Novavax are in phase 3 trials, so those will be available soon as well. So CDC infographic on how the mRNA vaccinations work. Lots of vaccine hesitancy causes issues for us, though. We have to reach 75 to 80% vaccination status for the entire nation in order to reach herd immunity for those who cannot get the vaccine or they don't work for. One study found that lots of barriers to vaccine acceptance. Some included confidence in the safety of the vaccines, confidence in the efficacy, perceived risks of the infection versus the perceived risks of the vaccination. Then there's accessibility issues, physical availability, health literacy, sociocultural appropriateness, social norms and past experiences. Specifically, a lot of people think that vaccinations cause autism. That was written in an article and then retracted later, but the effects still won't go away. That article, that study was actually published by someone who was found to have conflict of interest and was not valid at all. So evidence-based practice strategies to promote vaccination. They found that directly targeting the unvaccinated and undervaccinated populations helps. Aim at increasing knowledge and awareness. Improve the convenience and access. Target specific populations such as the local community. Employ reminders and follow-ups, and engage your local community leaders. Some education that you can tell people to help increase their knowledge is that vaccines are able to stimulate your innate immune system without stimulating adrenergic activity or your SNS fight or flight response. So you will get, the mild fever, muscle aches, headache, all of the mild symptoms that show that your body is producing an immune response to the vaccine, which is what we want, but it doesn't cause the systemic issues with heart rate, blood pressure, systemic inflammation, leading to the multi-system organ failure and death. And then people who are scared of vaccinations can be reassured with the Be Safe program through the CDC. And that program, you can just use it on your phone. It's an app. You can report any symptoms that you have, and it will notify you of any symptoms or issues going on. We have, a lot of people were concerned about the Johnson & Johnson vaccine. People did develop thrombosis with thrombocytopenia. That was 15 cases out of 7.98 million doses that were given. And that is a very rare side effect or complication that could happen, but that risk to benefit, you're going to get hypercoagulation and systemic inflammation with COVID much more severely. And then the mRNA vaccinations have shown some pericarditis or myocarditis, mostly in the younger men. So you do have two options to choose from, which would be your better choice. And then that's the main part of everything. I was not wanting to focus just on COVID. I wanted to do just infection prevention in general, but kind of went down the rabbit hole with COVID, and I know you guys did like 8 hours of a antimicrobial stewardship conference theme the other day, so I am going to not get on my soapbox on that, but some just quick facts. The other common infections endemic to nursing homes are UTIs, respiratory infections, skin and soft tissues, and GI tract. The most common condition that antibiotics are prescribed for are urinary tract infections, and up to a third of the antibiotics prescribed for UTI are actually not appropriate. They're given to people who have asymptomatic bacteria in the urine. 100% of people with long-term indwelling Foley catheters will have bacteria in the urine and should not be treated with antibiotics if they don't have any infection-specific UTI signs and symptoms. Respiratory infections, Mortality from pneumonia is 3 times more likely with poor oral hygiene, which can be found in nursing homes a lot of times. Skin and soft tissues. Pressure ulcers are always colonized with bacteria, just like the skin and gut, and they should never be treated with antibiotics without signs and symptoms of acute infection. And then the GI tract. Nursing home residents are 4 times more likely to die from viral or bacterial gastroenteritis due to dehydration. So according to Shane, 2021, in 1 year, 50 to 80% of long-term care facility residents will be prescribed an antibiotic for all types of suspected infection. However, 40 to 75% may be unnecessary or inappropriate. And it is recommended, generally accepted, to follow the Loeb criteria that states exactly when you should be prescribing antibiotics. Impacts on practice. Residents, employees, families, visitors, facilities, everyone benefits from improved infection prevention and control and antimicrobial stewardship. Decreased morbidity and mortality, decreased hospitalizations, shorter stays, decreased healthcare costs, and slowing down antimicrobial resistance. So everyone benefits from improved infection prevention and control, and that 1.5 trillion nationwide that can be saved annually breaks down to about $1,000 per resident annually that can be saved with antimicrobial stewardship. So a facility with 60 residents, that can equal $60,000 in costs. So, any questions?
No.
Okay, thanks.